Okay, so again, it's a pleasure to be here. I really do appreciate the introduction. If there's a way, there's a resize to change the video size or the number of videos. Okay, great. I got rid of it. Uh, I was asked to give a discussion today, and I thought that I would come up with something like this that I think has broad universal appeal to not just physicians, but also to paramedical staff, nursing, uh, and all educators, as well as to patients, as hopefully you'll soon learn about. This title of the talk is called the American Society of Reproductive Medicine Mullerian Anomaly Classification, otherwise now known as MAC 2021. And if you're able to advance slides for me, or if there's a way that I can navigate that, that would be great.
I don't think you can navigate through. I can just move on for you. Yeah,
And I'll raise my fingers when we can say go.
sure.
These are my disclosures. And a lot of this talk is predicated based on my colleague and our publication in 2021, which I refer to you, which is published in Fertility Sterility, called the ASR Mullerian Anomaly Classification, MAC 2021. Again, that was recently just published. Well, what are Mullerian anomalies and why are they so important? These are rare, probably occurring between, or definitely underestimated because not many have clinical presentations, but at least clinically present themselves between 1 to 5% of reproductive age women, where they're rare developmental anomalies of the female reproductive tract system. A woman, female, is conceived in utero with actually two halves of her Mullerian duct system that migrate down from the renal area down into the pelvic area. And sometimes they do not cannulate and fuse into one and cause a various number of clinical presentations, most notably pelvic pain, acute pelvic pain, chronic pelvic pain, and a particular emphasis on infertility. There are a number of proposed classifications for Mullerian anomalies. The classic one is the 1988 American Fertility Society classification, where we've been using this as a long classic standard for now over 30 plus years. I recently interviewed Dr. Bill Gibbons, who in collaboration with Dr. V.C. Buttram, and when asked and queried back in the 1970s and the early 1980s, when they came up with this classification that has since been used, he so eloquently stated that when we were looking at it, we looked at previous classifications and their outcomes, and they simply didn't make any sense with them at all. And with the goal to change the artificial classifications of the time and group anomalies to correlate with clinical manifestations, treatment, and prognosis of pregnancy outcome, thus providing clarity and greater uniformity. And this ultimately led to this iconic classification that we've now been using for 30 plus years. And for some, this may be familiar. For others, may not know what this is, but this is a long-standing classification for various different uterine anomalies. There's a number of advantages to using the AFS classification. And in this, the anomalies are represented by very, very simple drawings within each category, within each group. Their advantages are that they're very simple. They are easily recognizable and correlate with clinical pregnancy outcomes. However, as with anything, there are a number of critics. The AFS classification has been criticized for its focus on anomalies related solely to the uterus, with exclusion to the vagina and the cervix. Its lack of clear diagnostic criteria and its inability to classify a number of complex aberrations that may have a combination of the uterus, the cervix, and the vagina. This has since The 1988 AFS classification has led to more than 2,000 classifications since that time. There are some other notable classifications that I'm not going to belabor with you with, but some of you may be familiar with these. One is called the VCAUM classification that tries to categorize the vagina, the cervix, and the uterus and the adnexa with various nomenclatures such as VC, AC, V1, V2, R2, D2 classifications that make it very, very complicated. Others, such as ACN and ACN, have categorized based Mullerian anomalies according to their embryologic origin. And the European model, the ESHRA and ESCA classification, is based primarily on uterine anomalies or uterine anatomy with subclasses that they attempt to categorize. And then there's some that use very specific criteria using 3D ultrasound that not many of us have access to in order to make a diagnosis of these Mullerian anomalies. With that said, the AFS 1988 classification has stood the test of time. When I looked up the definition of standing the test of time, it is defined as continuing to be important, which it is, relevant, which it is, and respected for a long period of time, which it is. But with that said, despite the numerous classifications, the wide range of Mullerian anomalies is still largely unknown and confusing for physicians and also paramedical staff who may encounter patients with these anomalies. Additionally, the relative rarity and the limited exposure during training and practice makes this very, very challenging to assist patients. And probably the most important is that consequently, individual females may endure enormous delay in diagnosis, may undergo inappropriate or inadequate surgical intervention, and may have persistent issues, including chronic pelvic pain and loss of reproductive function. With that said, that is where we were tasked, or the American Society of Reproductive Medicine felt that there was a need for a new classification that was very apparent. And thus, the ASRM Task Force on Mullerian Anomaly Classification was formed and charged with updating the AFS classification. The ASRM tasked a task force, and this was led by our former CEO, Richard Reindaler, who tasked the lead, Sam Pfeiffer, who was the taskmaster to a bunch of us that you'll see in just a second. But enormous credit needs to go to Sarah Ramaya, who is the brainiac behind all of this, who helped implement this, as you'll see, this very, very interactive tool as we go through this. The task force members, including myself, were a number of American Society of Reproductive Surgeons who have expertise in the diagnosis of treatment and Mullerian anomalies. But we also felt that it was very, very important to represent those who are involved with adolescents, with representation from the North American Society of Pediatric and Adolescent Gynecology, as well as to radiologists who are doing a lot of the reading and imaging evaluation for these patients, and also to have staff with expertise in education and curriculum design. So there was a number of us who were tasked on this task force. Previous slide, please. Next slide. So we were given free rein to design a new classification. We were to we were tasked with preparing all existing classifications that were reviewed, and each were assessed for its advantages and disadvantages. And it was determined that an ideal classification should improve identification of all Mullerian anomalies, enhance communication between providers and research, and ultimately, the most important was to improve clinical care. It was also, we felt that we wanted to build on the strengths of the 1988 AFS classification. We wanted to keep it simple, understandable, and recognizable. So with that, as we got all this background information and we had what our main primary goals were, is that we came up with another 9 goals that I'm going to go through that were very, very critical and important to the task force. So in evaluating all of this, it was decided in a publication that we published here is that instead of starting all over, we decided that we would rebrand, much like other classic like Coca-Cola or IBM or Ford Motor or Apple or McDonald's, that instead of starting over, utilize something that was very, very successful. So we decided to rebrand. And in rebranding, we decided to keep it simple with line drawings. Again, keep it understandable with the grouping of anomalies and recognizable in capitalizing on the 1988 classification. Our next goal was that we decided to no longer number these. It was too confusing by having a number and just clearly leaving it as descriptive. So, in addition to having these categories, we decided to add 3 more categories, including longitudinal vaginal septum, transverse vaginal septum, and complex anomalies. Additionally, we wanted to standardize terminology. We wanted to communicate the essence of these anomalies through descriptive words and not through numeric classifications. Recognizing that there oftentimes is more than one way to describe anomaly, the task force listed them, um, but specified in this classification a preferred term. So therefore, we established consistency in terminology, and again, with the ultimate goal to simplify communication and recognizability. So in terms of standardizing this, again, I think what's really important that descriptively, if you look at the ESHRA, the classification where they have VC1, C3, U4, that we always joked around, if you could hit the next slide or hit next, please, that it was more like Star Wars. And what we wanted to do is we wanted to avoid that and get away from numeric classification. And that is the main reason that we wanted standardized terminology. I'm not sure if you're going forward or you're going backwards. So in addition, by identifying preferred terms, we establish which terms should now be used. And by being consistent, the goal was to facilitate communication, research, and search databases. So for example, you could look up in a scientific database somebody who has 2 uteri, and that would be described as a double uterus, or sometimes it's called ovira, or sometimes it's called HWW or Hurlin-Wunderlich, or really it's an obstructed hemivagina and ipsilateral renal anomaly. So therefore, by putting a preferred term in, we could have identifiable scientific databases so that we could ultimately come up with better research and outcomes. We wanted to educate providers on presentation, diagnosis, and management. And we implemented, as you'll see in just a couple of minutes, an interactive format to better educate across medical disciplines regarding the variety of anomalies, the presentation, the diagnosis, imaging modalities, and also medical and surgical management options. And again, the goal was to improve clinical outcomes. Now, what is so fabulous about this new interactive platform is that there's an educational element for each anomaly. They have 5 educational elements, as shown here on this, what's called the main educational element page. And these are intended to be used as one, as a reference for potential anomalies in each category, general information about learning on each category and anomalies within, and what diagnostic and treatment options are available for each of the particular type anomalies. And in this way, the task force hope was again the same common theme, was to improve overall patient care. So let's go through the educational element. And what you can see here with variants, when you click this button here, as I'm going to show you in a little bit, the variants button depicts all the represented variants for each section. It describes the possible configurations of the uterus, the cervix, and the vagina. And there's also a known as, which lists right here the possible names, and it underlines the preferred term, again, to help establish consistency in communication and literature searches. And there's the known button. In the similar widget, it depicts the anomalies that are similar in appearance, presentation, and imaging. And when you click on any of these, you can explore that anomaly, and it can also take you to the main page for that similar anomaly to explore the presentation, the imaging, and the treatment for comparison. Next is the presentation widget. And here you can click on the potential symptoms for each particular anomaly, the examination and key findings, and the differential diagnosis for conditions with similar presentations. And again, I'm saying the same theme over and over again here, is that we wanted to better educate about the typical presentation and educate about similar anomalies that may present the same way. This is a fabulous widget here. This is the imaging. It defines, in this particular case, when we click on this particular anomaly, that the MRI is the best imaging screening tool, and it gives us the best. As I had mentioned, there are 3 new additional categories. I'll just run through these really quickly: the longitudinal, transverse vaginal septums, and the complex Mullerian anomalies. We decided, or thought it was very important, by identifying preferred terms, we were able to have a consistent scientific database. And in this way, we can facilitate communication, research, and search databases in order to look at outcomes and best optimize patient care. It was very, very important and pivotal for us to work on educating providers on presentation, diagnosis, and management. We implemented an interactive format that I know that I started going through, and I'll quickly get to that. And again, the goal was to improve clinical outcomes. This educational element, as part of this MAC 2021, has 5 educational elements that are shown on the main educational page: variants, similar to, presentation, imaging, and treatment. In this way, again, our goal was to improve overall patient care. When you click on the variants button, what you're able to see is that it depicts all represented variants for each section. And not only does it describe previous uterine abnormalities, but it also now describes cervical and vaginal abnormalities. Additionally, it also shows known as, which lists all the possible names that all of us may be familiar with utilizing. But what it does is it shows the preferred term, so that, again, when we report this in the scientific literature, that we standardize things. Again, helping with consistency in communication and literature searches. In a similar widget that you can see here, it depicts anomalies that are similar in appearance, presentation, and imaging. And when you click on any of these abnormalities, you're able to explore within that anomaly, and it takes you to the main page, again, allowing you to explore the specific distal agenesis or cervical agenesis, that you can explore the presentation of these anomalies, imaging, and treatment for comparison. In the presentation section, when you click on this widget, what it does is it shows symptoms, examination, and differential diagnosis. And again, it was critically important for us to educate about the typical presentation and educate about the similar anomalies that may present in the same way. I think the most intriguing widget here is the imaging. And with regards to this, what it does is it provides imaging tips that many radiologists or doctors, physicians may not be clear or aware of. There are three types of imaging that we routinely use: the MRI, the HSG, and the ultrasound. In this particular Mullerian agenesis anomaly, HSG and an ultrasound would be relevant, so you can't hover over it, but you can click the MRI button. And what it does is it educates the user on the available imaging modalities to confirm the correct diagnosis. And what you're able to do is compare your images to existing standards in the industry. And there's arrows highlighting relevant or important components to your imaging. In the treatment, what it does is it discusses or allows us in this widget here to look at medical options, dilation options, and also surgical options. And in the near future, we're going to be adding video links that, while it will not usurp standards in the industry, will give overview of different types of surgical intervention. Again, educating the user on surgical and non-surgical treatment options, and demonstrating that there's a range of options for patient care. And probably the most important part of this was promoting awareness, patient awareness and advocacy. And this is ideal for patient education. Patients can go in and click on any of these widgets for interactive learning. Some of these Mullerian anomalies have, these patients have suffered significant delay in diagnosis or definitive treatment, and patients may want a better wish to be educated regarding their condition because they're not getting adequate information, and it may empower them to seek earlier evaluation and intervention. So some of the important features of MAC 2021. And this is critical here because, one, you can still print out. You can print out the old version. You can print out the new version because some are just not computer savvy and don't want to do the interactive platform that I'll show you in just a second. And so simply printing it out will show you the new classification. There's enormous flexibility here. The aim is to include most of the anomalies that have been described, but better yet, we recognize that there's new anomalies that are always coming up and down the pike. All the potential variations that could be seen, what we can do is we continually add, and going into the future, what is really, really important is that this MAC 2021 allows us to continually update all the variations, all of the different types of anomalies that are continually being described, and that we don't have to wait another 30 plus years to go ahead and rebrand and update the AFS classification. And that's the exciting part to this interactive platform, is the continual update. Some of the other important elements of this is that we redefine the septate uterus and the bicornuate uterus, that instead of being 1.5 centimeters in terms of a fundal indentation, it's now simply, based on all the literature, of 1 centimeter. No longer do we define an arcuate uterus as abnormal. It is just a variant of normal. In terms of validation, design, and technology and flow, ASRM MAC 2021 was shown to various groups of individuals for feedback regarding the content, the usability, and the flow, and its educational merits. This group included members of the American Society of Reproductive Medicine, trainees in obstetrics and gynecology and reproductive endocrinology, medical students, and members of the practice committee of ASRM, and lastly, lay public on the usability, the visual appearance, and the interactive elements. So we did what we could to make sure that we could justify and validate its applicability. The design came through in Adobe software and included 81 screens of interface items with visual elements, hover elements, and colors for high fidelity and interactive user experience. There is, as you'll see in just a second, there's what's called a linear interaction. It allows the user to transition linearly across each anomaly, or there's what's called a self-directed interaction that allows one to interact across the various different anomalies and widgets based on the direction that you want to go. So the tool can be used in several different ways. It can categorize Mullerian anomalies in a simple and clear way using diagrams and descriptive terminology. It can be used as a reference for preferred nomenclature, as an educational reference to study Mullerian anomalies and correlate presentation, imaging, and treatment, and as an educational tool to compare and contrast anomalies with one another, we call self-directed flow, and as a reference to aid in the diagnosis and treatment of a patient who does present with symptoms suggestive of a Mullerian anomaly. Now, what is really, really important is that MAC 2021 reflects appropriate management. It is not intended to be the only approved standard of practice or dictate exclusive course of treatment. And that other plans of management may be appropriate, taking into the account the individual needs of the patient, available resources, and potentially clinical practice limitations. So what I want to do is I'd like to show you and explore this MAC 2021 tool. This is a video that we put together with my colleague, Dr. Phil Romansky and Sam Pfeiffer. This is going to take you through
the ASRM
the tool.
Mullerian anomaly classification was last updated in 1988. Recently, ASRM revised its classification and rebranded it as the ASRM Mullerian Anomalies Classification 2021. Beyond the main goals of this update, described in the video abstract, MAC 2021 expands beyond a static reference into an educational interactive tool. In this video, we will provide a tutorial for how providers, learners, and patients can navigate and utilize MAC 2021 to develop a differential diagnosis, compare a patient's presentation with exam and imaging findings, and ultimately assist in correctly classifying, diagnosing, and treating Mullerian anomalies. For demonstrative purposes, we present two example cases to highlight how the interactive tool can best be leveraged. Example number 1. A 26-year-old G0 presents to her gynecologist for a preconception visit. She was recently treated at an outside hospital for appendicitis and was told her pelvic imaging revealed she had a, quote, double uterus. She reports no other relevant history. Given this vague history, the physician accesses the MAC 2021 website to consider the possible anomaly that could be present. The home page provides an overview of MAC 2021 and its goals, as well as an image of the AFS 1988 classification figure. MAC 2021 can then be accessed by clicking on the blue Click Here to View ASRM MAC 2021 hyperlink. Navigation tips are provided at the top of the page. Scroll down to view the 9 different MAC 2021 Mullerian anomaly categories, including the newly categorized longitudinal vaginal septum, transverse vaginal septum, and complex anomalies. For this example, the physician elects to navigate to the bicornuate uterus category given the patient's description. The patient provides a copy of the pelvic MRI images. The physician clicks on the MAC 2021 Imaging tab to make a comparison. Listed here is the diagnostic strategies, findings, and tips. Example images from multiple imaging modalities are also provided. They then click on the MRI link to review the example images. On the patient's MRI, the physician notes the uterus to have a single external body with a flat fundal edge with the endometrial cavity divided by a septum, which is different than the fundal indentation noted on the imaging examples of a bicornuate uterus. They then realize the patient appears to have a septate uterus and switches to that category to confirm by using the self-directed flow. After confirming the patient's imaging is consistent with a septate uterus, the Similar To tab can be clicked to see whether other anomalies should be considered. This link lists other anomaly categories that are similar in presentation or imaging to the suspected anomaly. While the physician recognizes here that there are multiple anomalies which could be colloquially referred to as a double uterus, it is clear that the septate uterus is the only one with a single external uterine body as seen on the pelvic MRI, and the physician confirms the patient must have a septate uterus. Next, to determine the type of septate uterus, the variance link can be used to view the known associated variance for each anomaly. While the physician already recognized the anomaly as a complete septate uterus, the variance page quickly shows that this anomaly can occur with or without a longitudinal septum and with a single or duplicated cervix, and can also occur with an obstructed hemivagina. This helps the physician to remember important anatomy to evaluate on the physical exam. Example number 2. 14-year-old G0 is referred to a gynecologist with a suspected diagnosis of Mullerian agenesis after presenting to her primary care with amenorrhea. A blind vaginal canal was observed on exam with no cervix or uterine body identified on imaging. To corroborate these findings, the gynecologist navigates to MAC 2021 and clicks to expand the Mullerian agenesis category. After reviewing the possible variations, they navigate to the Presentation tab to review the expected symptoms and exam findings. Here, the differential diagnosis is listed to help guide the physician where important reminders are listed when relevant. Once the diagnosis of Mullerian agenesis is confirmed, treatment options can then be considered. The indications for treatment of Müllerian anomalies are specific to each anomaly and presentation and are beyond the scope of the classification tool. However, the treatment link provides useful guidance regarding treatment options that the physician should be aware of and can be considered when appropriate. The physician sees here that for Müllerian agenesis, medication, dilation, and surgical treatments are all potential options. Soon, surgical video examples will also be added to assist with preoperative patient education and counseling. Finally, the classification link will direct the physician back to the MAC 2021 classification page, where each anomaly category can be expanded and further explored, similar to the examples demonstrated in this video. In conclusion, the ASRM MAC 2021 provides an updated Müllerian anomaly classification system while maintaining its simplicity that now uses descriptive terminology to standardize communication and recognizability of these anomalies. Providers should become familiar with the MAC 2021 interactive website that can be used, first, by women's health providers to synthesize a patient's presenting symptoms, physical exam, and imaging findings to develop a broad differential diagnosis, rule out incorrect diagnoses, and eventually make the correct diagnosis. Second, by medical trainees to learn about Müllerian anomalies, including the categories and variations, as well as the typical presentation, exam, and imaging findings and possible treatment options. And third, to continually review and update this live format as novel, rare, or complex variations are identified to ensure that providers have access to the most up-to-date information about Müllerian anomalies.
So, in conclusion, there are many proposed classifications for Müllerian anomalies, and each has advantages and disadvantages. The 1988 classification has been around for the longest time and is the most used and recognizable. However, there was a need to update the ASRM classification, particularly with the new technology that we have. The task force was brought together utilizing experts in the field of reproductive medicine and surgery, adolescent gynecology, and radiology, and we identified goals for what the classification should accomplish and focus foremost on expanding and clarifying the 1988 classification. As important was the educational and research opportunities with the mindset of improving patient care by providing an enhanced tool for conveying the wide variety of anomalies, diagnostic modalities, and medical and surgical interventions was equally important to us, student learners, and most importantly, patients. It is really important that this could never have happened. It took over 3 years to create this. This report was developed by the task force under the direction of the practice committee of the American Society of Reproductive Medicine. And although, again, this document reflects appropriate management of problems encountered in daily practice, it is not intended to be the only approved standard of practice or dictate treatment. Other plans of management certainly may be appropriate, taking into account the needs of the patient, available resources, and institutional or clinical practice limitations. Finally, the task force, the practice committee, and the board of directors at ASRM approved this MAC 2021. This could not have been done. This was a project of masses, and there were enormous contributions of the practice committee, as well as a number of others that helped identify background literature, as we reviewed probably close to 5,000 publications in this area. So with that, I thank you. I do